I was asked to teach you guys how to develop a trustworthy practice guideline. Obviously, I won't be able to achieve that. Of note, we usually offer a 3-month course online to teach our master's students how to develop practice guidelines. However, what I'm trying to do today is to at least go over the principles that we can put together to come up with a trustworthy guideline, and also go overview the process. These are my disclosures. How many in the room have participated in clinical practice guidelines before? A couple of hands. How many have read or used clinical practice guidelines in practice? So majority of people have some background about practice guidelines, which is good. Okay, so I thought the best way to approach this is to take an example. So let's assume that we're trying to develop a recommendation on a clinical condition that tackles both of my specialties as a gastroenterologist and intensivist, which is GI prophylaxis in the ICU. So we're prescribing stress ulcer prophylaxis in mechanically ventilated patients in the ICU. And there are, as you can see, multiple options. And one way to deal with this, to come up with the recommendation, is to bring a bunch of experts, close the doors, and ask them to debate and come up with recommendations. It's easy, as it sounds. However, there are risks. Some people might end up being vocal and end up with stronger recommendations, although they might not know what they're saying. The guideline structure that everybody should be familiar with starts with putting together the team. So the chairs, the methodologists, the panel members, and usually you would like to have experts in the field, frontline clinicians, and sometimes patient representatives as well can be incorporated into the panel as well. If you have the luxury of having more financial support and time and energy, you could have a systematic review team who would come up with the systematic reviews, as Dr. Gait explained in his previous lecture. But also, management of conflict of interest is extremely important, and it's advisable to have a conflict of interest adjudicating committee. Obviously, before starting any guideline, you need to decide about the scope of the guideline, the topics, the target audience or the end users of the guideline, and the timelines. You might imagine that guidelines may take a long time to develop. For example, the Surviving Sepsis Campaign guidelines that was published this year took us about 2 years to complete. If you need more resources, you can check out the checklist developed by some of our colleagues at McMaster and the GRADE Working Group. It's available online. I would start with a few key points. First key point is about conflict of interest management. The influence of conflict of interest management should be minimized in any guideline. And this is extremely important. And the conflict of interest can have several types. It can be financial, and that's easy to quantify or at least describe, as long as people are describing or disclosing what financial conflict they have. The more challenging ones and the more problematic is the intellectual or academic conflict of interest, in which people who are expert in the field or have led major trials in the field, they may have some sort of intrinsic bias to one way or another that could affect their judgment. There are several approaches that we can deal with conflict of interest. And again, this could be a separate talk on its own, but either to ignore them if they are minimal, or you could ask people to declare their conflict of interest. But people with major or primary conflict of interest probably should not participate in formulating the recommendation. Okay, so people with primary financial conflict of interest, for example, should not be participating in the recommendations, or panel members with primary intellectual conflict of interest as well should avoid contributing to the final recommendation. Recently in JAMA, there was this nice paper that looked into conflict of interest in clinical practice guidelines. However, I was surprised they did not address the intellectual conflict of interest at all. And I can tell you all kinds of stories confidentially in the workshop if we happen to meet. Okay, I love this slide, and I like showing it all the time because it summarizes the guideline development process from the beginning until the recommendation phase. If you follow the, supposed to be there a green arrow on the top. It's just behind that timeline. So any guideline development starts with formulation of the PICO questions. and I won't go into a lot of details here. However, I would like to say that questions should be clear, comprehensive, and actionable, and the interventions or the course of action and the alternative course of action should be clear and explicit. Okay? We've talked about the PICO format in the previous lecture, so I won't spend time here. And back to our guideline that or the recommendation that we're going to develop together. So that one question or appropriate question can be phrased as follow. In adult mechanically ventilated patients, that's your population, should we recommend using PPIs or proton pump inhibitors, which are some kind of antacids, over H2 receptor antagonists for GI bleeding prophylaxis? What's missing here is the outcomes. So the next step is to come up with a list of outcomes that could be important for decision making. Okay? And could be looked like this in more details. As you can see, there is a clear description about the intervention, the control, and there's a bunch of outcomes included there that you can see. Should we include, what outcomes should we be including? How many? All these questions come to mind. There should be a process in a credible guideline to allow panel members to prioritize which outcomes to go into decision making. So the outcome should be critical for patients and decision making. Some of the outcome may be interesting from a scientific point of view. However, it's very irrelevant to patients. And the outcome should be related to the intervention itself. So let's say if you're looking at a skin ointment to treat a skin condition, although mortality may be important or crucial for patients, however, it's completely irrelevant in this case. Ideally, we'd like to keep the number of outcomes between 5 and 7, just to make it manageable and comprehensible when you come up to make the recommendations. One way to deal with this is to rate the outcomes on a scale from 1 to 9. I'm going to show you in the next figure how does that look like. So these are the outcomes that I've presented in the first slide. And the scale runs from 1 to 9. You ask the panel members to rate the outcome according to the importance. So 1 being completely unimportant, and 9 is the most critical outcome that you can think of. And you draw the thresholds. So any outcome that scores less than 3, they are not important and probably should not be included in any decision making. Obviously, things like gastric pH, for example, or colonization are completely irrelevant to patients. They might say, well, I don't care what's my pH in the stomach if I use the medication. However, I do care if I'm going to develop a GI bleed or pneumonia or if I'm going to die. Therefore, as you can see predictably here in the yellow, outcomes highlighted in yellow, they all pass the threshold and they should be considered as critical and they should be evaluated when making the decision. So, assuming you got the PICO question right, you identified the outcomes and you prioritized them accurately, the next step is to do the systematic review. So you want to look for the best available evidence. And again, I won't go through much details here as Professor Guide covered this already in his lecture. However, I would like to say that all recommendations should be based on the current best evidence. You might find, a well-done systematic review from 2008, however, it's outdated. So it needs to be updated as well. So this is what we did. We found this systematic review that we published, and hopefully you find something like this, a forest plot for each of the outcomes that you want to assess. And as you can see, there are several studies there. One of the reasons you don't want to look at the individual studies, and believe me when I say that, I've worked with guideline panels where they assessed each of the studies individually, and obviously you lose a lot of the information, as you have seen with the previous talk, that this can result into a false assumptions or even imprecise estimates. The next step after summarizing the evidence is to assess the quality of evidence. So you want to come up with evidence profiles that shows the quality of the evidence, the magnitude of treatment effect, etc. And the assessment of quality of evidence need to be comprehensive, explicit, and transparent. And the assessment should be done as per outcome level, as I'm going to show you in the next few slides. We keep referring to quality of evidence. You might hear the terminology confidence or certainty. They all refer to the same thing. Okay. And I'm not going to talk about the categories as Dr. Guide already covered this. If you look at the published guidelines, there are several methods have been used in the past. However, I think GRADE is one of the most widely used methodology and probably the most comprehensive, although I have to acknowledge that I'm biased using it all the time and being a member of the GREAT working group. So what you're hoping to come up with is something like that. So this is an evidence profile showing you the outcomes and the assessment of quality of evidence per outcome. So the far right-hand side there, you see the quality of the evidence, and it's assessed for each of the outcomes. And this is important. And I just want to highlight that, for example, the Clostridium difficile infection, which is a bacterial infection that can happen with acid suppressive therapy, is only addressed in observational studies. There are none of the randomized trials, which is, I think, were like total 19 RCTs over the last 20 years, have addressed Clostridium difficile infection. Therefore, it's not fair to treat C. diff or Clostridium difficile outcome similar to GI bleeding, where GI bleeding was reported in most of the trials. So you have to make sure that panel members, or yourself, when you're developing guidelines, assess the quality of evidence per outcome. And again, the other thing I want to highlight here, just to keep the story together, you can see, so in the absolute difference here suggests a 15 fewer bleeds per thousand if you give PPIs over H2 blockers, so there is moderate reduction in bleeding, and there may be a small increase in risk of Clostridium difficile, about 0.7% or 7 per thousand events. So again, a very small increase in C. diff, but it's there. After summarizing the evidence and assessing the quality of evidence, the next step would be is to rate the overall quality of evidence. And don't be deceived with these smiley faces. We hope that people, are happy at this stage. However, they look more like this when it comes to discussing the evidence and coming up with recommendations. A lot of discussion. It's important to have feedback from panel members and discuss this between the methodologists and the panel members. But also, more importantly, is considering other variables. So having the magnitude of benefit or harm and having the quality of evidence are not enough to allow a panel member or a panel of experts to make a informed or an accurate recommendations. There are other things as well that comes into the equation, like values of preferences and cost. So I'm going to focus more on patient values of preferences. So a credible guideline should appropriately specify values of preferences for each of the outcomes. It's not that easy, as studies are needed. I can speak about the critical care field, for example. Studies are very, very deficient when it comes to values of preferences of patients in the intensive care unit. And the other question is, who should be, providing input here? Are they patients who've experienced the condition, or patients who did not, et cetera? Several questions that you need to think of when it comes to, designing those studies. However, for the purpose of developing guidelines, to make it credible, you have to consider values of preferences of patients. This could be done in several ways. You could conduct your own values of preferences studies, surveying, large sample of patients, and then understanding what they prefer across the outcomes of interest. However, it's labor-intensive, requires funding, and requires time. The other thing you can do is to search the literature, and there are key mesh terms that you can use, and we have published recently that can help you identify those studies. And if you're lucky, you find some, and if you're even more lucky, you can have some sort of a summary across those studies that can help you make the decisions. Or a more common approach is to have a patient representative involved in the guidelines, and this is what we have done, for example, in surviving sepsis and other guidelines we're working on, just because of the constraints of time and the fact that there are no much studies available. However, we acknowledge that this is probably a limited approach and unrepresentative of the overall opinion. Another less credible way is to ask experts to provide input on behalf of their patients. And things like that we encountered recently. For example, would patients prefer to be deeply sedated in the ICU versus not? And, we had interesting discussions in one of the guideline committees, but there was a split between the experts. I thought initially, with my own intrinsic bias, that most patients would say, please don't sedate me, I want to get off the ventilator sooner. However, some of the experts said, well, patients would value not experiencing getting scared while on the ventilator, so they want to be deeply sedated, even if that means they stay on the ventilator for 1 day longer. Again, It's not the ideal way. However, across this range, your confidence in the appropriateness of application of values of preferences will change. The thing you don't want to do is to ignore this completely. Okay, so how do you decide? I'm not going to go into the details, but again, we have two competing outcomes. So PPIs could reduce bleeding, but may increase pneumonia and C. diff. It all depends on how much patient value one outcome over the other, or the trade-off between these two outcomes. So if we survey a large number of patients and there is a small variability in what they prefer, for example, if majority prefer not having a bleed and they don't care about having a pneumonia because they can get antibiotics for it or C. diff, then we'll be more inclined to issue a strong recommendation. However, if there's a large variability in which we are uncertain what patients prefer, it would be very difficult for us to say everybody should be using PPIs because we don't know what patients prefer, and it has to be at best weak recommendation with discussion with patients. Okay, so the last part is issuing the recommendation after factoring in all these components. Authors should indicate the strength of recommendation. It's not enough only to issue a recommendation, but authors should indicate the strength, and usually the strength are either a strong recommendation, usually stated as we recommend, or a conditional, what we call weak recommendations, in the form of we suggest this intervention, for example, or we suggest not using this intervention. Also, the direction of the recommendation is important to highlight, obviously, and the recommendation needs to be easy to read and easy to understand for clinician. Avoid complex, long statements which can be confusing to readers. Things that might lead to a strong recommendation, for example, if you have a high to moderate or moderate quality evidence, obviously if there is a large benefit, a small or negligible harm, and small variability in values and preferences of patients, low cost and resources, then obviously that's a slam dunk, strong recommendation. People would argue against this. For conditional recommendation, multiple scenarios. One of them, if you have a very low quality evidence, so you're uncertain about the treatment effect, and there is, for example, large variability in values of preferences of patients, or if there is large cost or feasibility issues, then it would be hard to issue a strong recommendation for that intervention. Okay, going back to our recommendation. So looking at PPIs and H2 blockers, let's assume we have low overall quality evidence of moderate benefit, which is reduction in GI bleed, but there is a small harm in terms of increasing risk of C. diff, and there's uncertainty about values of preferences of patients, and a couple of cost-effectiveness studies suggesting that PPIs may be cost-effective. Well, overall, panel members may judge that the desirable consequences of prescribing PPIs outweighs the undesirable consequences of not. Therefore, they may end up with a weak recommendation or a conditional recommendation favoring PPIs over H2 blockers. You notice that you should always indicate the strength of the recommendation, the direction of the recommendation, and it's better also to be explicit about the alternative, which is H2 blockers here. So to summarize what we have said, to get a trustworthy guideline, it's not an easy task. It's a very lengthy process. However, the basic concepts you need to keep in mind, you have to have an explicit definition of the question, a systematic review of the evidence, or attempt to identify the best summary of evidence available, and also have a comprehensive assessment of the quality of evidence per outcome. And when making a recommendation, please specify the strength of the recommendation, the direction of the recommendation, and also when you present it, ideally, the recommendation should be linked to some sort of an evidence or an evidence profile. I would like to take the last 50 seconds to mention a few helpful resources. User's guide as well can be very helpful if you want to go into more details. There is also the AGREE tool that has been published to assess the reporting or the credibility of practice guidelines. Also may have some interesting things to go over to consolidate the ideas. But also you can read the JCE series, and also you could check the MacGrade Center website. They have a lot of educational videos there, short videos, and or several handbooks that are available online as well. And I think we're done. Thank you.